system to think, immediately like it was 1 rupee and 10 paisa. The bat is 1 rupee is costlier than the ball, and how much is the ball? So what immediately comes to mind? 10 paisa. That's system one thinking. We should not be doing lot of system one thinking when we handle emergency patient, right? We have to think in terms of system two thinking. Like you have some kind of reasoning and analysis. Okay. Now, when we handle patient, the first and foremost important thing is that solid training base. For that we have come, right? Without solid training base, I mean you need to have all support courses like sir has taught ATLS, ACTLS, ACLS, your PALS or now team. Okay, that is very important. And when you come, then you must do a 0 point survey. So 0 point survey is like what Dr. Budru said, that the teamwork, like you can have that 0 point survey with a step up. Yourself, your team, environment, your patients, your update priorities, but we don't get updates in India. So, but we should do 0 point survey whenever we come to the emergency department. Your equipments are working. And second, that we have to be research ready all the time. Research ready means that we have all the equipments like IUSS, blood, plasma, beer hugger, warmer. So we must, because emergency is anything, anyone, anytime. So you have to mentally visualize that any kind of patient, even pediatric, old, any kind of patient can come. So you have to be research ready all the time. That's we lack in India. Okay. Keep going. Now one concept is cognitive aid. So because there is a plethora of information, so much is changing, medicine is changing very fast. So maybe you don't remember. Like if I ask you what is the dose of vasopressin in the trauma, so maybe maybe you don't know. So you ask one of your team member, maybe 5 milligram in next 8 hours. But military trauma 82 gram upfront. So if you don't know anything, go online, ask one of your team members to go online and find it. Right? That's concept of cognitive aid. Next. Now when we are working in emergency department, we must have our SOPs, algorithm, closed loop communication. Closed loop communication is like if I ask you to give 1 milligram of midazolam, then you will acknowledge that 1 milligram of midazolam, then you give it, and I will receive the message. So this is closed loop communication. This is very, very important, and you have to speak clearly and loudly because there is a chaos, there is a lot of sounds. So you have to. It happens in either hospital also. Somebody comes and give 1 milligram, and he doesn't speak very loudly. So again, second person will come with midazolam. So one thing is that speak clearly and loudly because there is a very chaotic. Because I deal with very sick patient and multiple things are to be done simultaneously. So speak clearly and speak loudly. Okay. So I told you you have to do all life support courses. Next. Then whenever a patient comes, like if we have a patient of gunshot injury, so you feel threatened or challenged? Because I feel threatened. And if you feel threatened, then what will you have? Flight or fight reaction or freeze reaction. We don't want to happen there because we cannot run away from the patient, we cannot fight with the patient, we cannot freeze. Obviously, we can freeze if you are not trained. So, but we should not have that amygdala hijack. So, what should we do so that we don't have that threatening effect or fight or flight reaction? So you can have challenge. So how you can have that kind of, like you take the patient as a challenge. So when you have a good team, like Dr. Gundur said, like you have a good solid training based team, your teamwork is good and your SOPs, you have done 0 point surveys, you are research study, and then most importantly thing, now I tell you why I am talking about this and why I am insisting all the time to sir. Like if we give a gun to a chowkidar and give him 7 days of training and we send him to the border, will he fight or not? Will he be a good soldier? Or we train him for 7 days, give him a gun and tell him that you need to kill and you will be killed. So that his mindset is prepared. So most important thing, like what is lacking in India, we don't have an emergency mindset. It's not on the skill. You come and learn skill, but you don't have a mindset. You are doing skill, but you are not confident. What is the outcome? Maybe suboptimal performance. So this is why I am insisting in all the forum, let's have a first emergency mindset. How can you not have a fight or flight reaction? By having a good team, by having your SOPs, by having your algorithm, having research readiness. Like you don't have an eye reaction, put an eye on eye. Patient of bleed comes, stop the bleed, start the blood. Start the blood early. So that should be our mindset, right? So this is very important. Like this patient comes, play the video. So this patient of gunshot injury. See, the patient comes like this because in India it's a drop. You don't get any update. So just say silent. So this patient comes, everybody is shouting, and then you also get frightened. No, it's a gunshot injury, 4 gunshot. So now if we have like, now I am trained. So what you do? Beat yourself. Just beat yourself. Beat the stressful. So whenever you feel, nervous, panicky, just breathing. So in breathing, your expiration has to be more than your inhalation. That calm down your adrenal surge and that activate your vagus nerve. You do it. I do it many times. And then B is breathing, T is self-positive talk. Yes, I have been trained. I have taken care of such patient. I will take care of this patient also. Okay. Then S is C. Visualize hospital. And then we don't have anything to plan. So our hospitals are different. We are dealing with the mini disaster every day. So it is not like we need to have a disaster. Every day there is a disaster. सरकार वो बड़ा होता है सर मैं इसको उठा रहा हूँ कोर्ट में पेशेंट आया you don't have any information, right? So you definitely will get stressed. There's nobody, patient is sick, is bleeding, he has got polytrauma. What will you do? So then do BTS, self-positive talk, and then C, visualize what I'm going to do, right? Like a polytrauma, so we will stabilize him, blow, blood, whatever, and then focus. Whatever you do, try to focus on that particular task. Don't get distracted. So BTSF is the way you can knock off that panic attack. Next. So now these are the few examples. Now you play this video, this one. So this is situational awareness. This is the patient like came with, heart is visible, lung is visible, audio. So anyway, one of the sisters says, "Sir ko bulao, sir ko." So she has situational awareness, like you will not be able to handle this patient. Please call sir immediately. That's the situational awareness. It is not only the situation about the team member or the team leader, but sometimes we get distracted. So it's the duty of the team leader to bring back the team member into the situation, because we get distracted because they are doing and we start thinking something else. So situation awareness, what has happened, what is happening, what might happen. So this patient is very sick. He has open chest, and then we need senior person immediately, right? Then you must have a plan B. Whenever you do something, you must have a plan B. This is a very famous example, Alan Bromley. Do you have a slide? First video. So simple nasal surgery, she went to UK 2009, she was induced and they could not intubate, and one after another, bronchoscope, senior doctor came, that Dr. Guntur said, fixation, tunnel vision, we will intubate. Somebody told, just go for tracheostomy, not surgical try, but they were not ready, like they were very overconfident, and the result, patient died. So her husband, Martin Bromley, now tells human factor. They are teaching human factors. Okay, second video. So similarly, I got this patient. I was not able, second video. I was not able to intubate. Then I did what I am doing here. No, it's not tracheostomy. This is a very great confusion about surgical pneumothyroidotomy and tracheostomy. I am doing surgical pneumothyroidotomy. That's the emergency surgical area, not the tracheostomy. And we could save the patient. Right? So you must have a plan B whenever you are doing something, or plan C. Okay? So that one. Next. Now you have cognitive biases. Like whatever somebody write in the first place, we keep on writing again and again in the file, right? Although we are getting investigation which are not supporting their diagnosis, but still we are biased. Okay, so we must avoid those biases. And then, like play this fourth one, like we are supposed to apply a cervical border, but patient was conscious. He said there is no pain, but still we applied. Somebody else, he came to us. Somebody applied the cervical border because we are biased. Any patient coming with trauma applies cervical border, but patient is conscious. He doesn't have any neck pain. Don't apply. There's no need. Okay, next time. Then flexible. You need to be flexible when you work. It's not like rigid. Algorithm there to help you, but they are not. They should not be regimented. I guess I will do it. Like if we are doing DDM and saturation will maintain, there is no need to intubate. But there are other things. Just we'll move on. Pre-mortem, like a patient of chest trauma comes, he dies. So what are the various organs in the chest with which the patient can die? Organ in the chest, we can kill the patient. Injury to those organs can kill the patient. Heart, lungs. I said speak loudly and clearly. Read before that. Esophagus, aorta, diaphragm, sometimes liver. So let's suppose patient dies. So next time, if this patient of chest trauma comes, so we will consider all these organ injury. Then we will be able to tackle it more efficiently and more rapidly. Okay. That don't give opportunity to unnecessary failure. Like we are trying to, intubate a patient who has got full stomach, right? So avoid opportunity for unnecessary. Like we are doing intubation and not keeping the surgical crime. So this is an opportunity for unnecessary failure. So avoid that whenever you do something. Okay. Then dealing with uncertainty. So this is a patient. If you can play the video. Sometimes you deal with patient which is survival injury. So this is the patient like we did the recessive choromorbid, but he didn't survive. But doesn't mean that you are not a good doctor. You must not suffer from the imposter syndrome. That why I become a doctor. Because these things happen. Okay, so you deal with the uncertainty, but don't suffer from imposter syndrome. Okay, next slide. Never waste suffering over patient, right? Patient has died, you must learn. You try to find your blind spot because blind spots are here. I can see your blind spot, but you cannot see mine. So through debriefing, you can find, like, you should not, if we are not able to save any patient, we should learn whatever we could do better. Okay, next. So these are the things that we should have when we are working in the emergency department. Now coming to the primary survey. ये सर 20 मिनट है ना मेरा तो 5 मिनट लगे हाँ तो अभी सर 5 वो एक्सरसाइज भी करते हैं